Today I will report the case of a patient who presented foreign body from penetrating trauma localized inside the lens. The patient reports that at the time of the trauma he did not present any particular symptoms while he was working on a marine engine with metallic material. After about 3 months, he reported visual loss in affected eye. The presence of corneal leucoma at 5:30 inferior quadrant and iridotomy in correspondence was visible on slit lamp and scheimpflung image, and on immersion bulbar ultrasound the foreign body was localized within the capsular bag. We also performed CT, which demonstrates the presence of the foreign body approximately in 1.6 mm in size with localization inside the lens, and excludes further material localized in other districts. The surgery aims to remove the foreign body. The cataract implanted the IOL in capsular bag, avoiding complication due to the damage of the anterior capsule by the foreign body entry and the potential damage to the capsular bag due to the movements of the foreign body during a cataract extraction. Therefore, after having performed the keratosynthesis with the main axis of 2 mm in size, we proceeded with the injection of cohesive OVD. I prefer to start with the incision of the capsular rexi close to the capsular entry point of the foreign body, and that at this time is fibrotic already. Moving counterclockwise, it allows me to get the damage point of the capsular bag at the end of the rexis, limiting the damage of the hypothetical capsular escape, which in any case did not occur. I then proceeded with the careful hydrodissection in order not to mobilize the foreign body too much. It is not possible to start the phacoemulsification due to the possible movements induced by fluidics on the foreign body, which could damage the capsular bag. So I inserted the magnet, but there is no attraction, as we will then understand that the foreign body is made of aluminum. I injected then OVD below the foreign body to move it away from the posterior capsule. With the forceps, I hook the foreign body and remove it from the lens through the corneal incision. In order to avoid pressure on the zonal capsular bag, in order so to avoid lens iris diaphragm retropulsion syndrome, I was lifting up the iris, allowing the water to go through the zonula. Then I performed the removal of lens in aspiration. and implantation of intraocular lens in the bag with optics perpendicular to the foreign body entry point to assure greater stability of the capsular bag. At the end, with vitreous forceps and scissors, I was cutting the edge of the capsular axis that was not perfectly circular. So the first day post-op, the IOL was in place, centered in capsular bag. Thank you very much.